for Breast and Thoracic Service at prestigious Rajiv Gandhi Cancer Institute. More than 37 years of medical oncology experience, has participated in more than 60 international and national studies, and is also recipient of Medical Excellence Award, Work Hard India, and many people's his credit. I have personally learned a lot from Dr. D. Doble. The second eminent honorable person or lady chairperson for this evening today is none other than Dr. Kalai Chalvi ma'am. All of you know her. She is the senior consultant medical oncologist at Apollo Specialty Cancer Hospital. She's been responsible for creating many DM students across the country and in the world. DM oncology she finished in March 1996 at prestigious Cancer Institute, India, and she was earlier HOD and Professor Department of Medical Oncology, Madras Medical College, and close to 25 years of clinical experience, has presented in various national and international conferences. So may I request both the chairpersons to introduce our expert who would be speaking to the DM and DNB students tonight. Dr. Doval sir and Kalai Chalvi ma'am.
Good evening to all of you, and it's my pleasure to invite Dr. Govind Babu. I think I left a legacy when I left Kidwai, and there was a register which used to carry the names of all the patients getting chemotherapy for various diseases, and one register had lung also. And that time we used to use endoxifen tablets. We did not have any drugs. We hardly had cisplatin and carboplatin available to us, and we didn't have pemetrexed or any of the targeted agents. And it was that time that we had an Indo-US CME, and I gave Govind Babu the topic of molecular biology in lung cancer. And he has done great with the subject that he has been doing, and he has really taken that forward. And today we have come a long way in treatment of lung cancer. We are talking of druggable mutations, and we are talking of driver mutations and non-driver mutations, how to treat the patients. We do not have any drug, but now we have plethora of drugs, and our patients with lung cancer are living very, very long. I'll give you just one example. I had a patient whom I had put on ISL study. She was taken in 2003-2004. ISL study was negative, and she was taken off the trial, and she was put on compassionate ground on the tablet. We unblinded the thing, and we found that she was getting gefitinib. This lady is one of the longest survival. She survived for about 14 years. In 13 or 14, she had relapse in the liver. We did a biopsy, and it was found to be mutation in exon 19. So, lots of targeted therapies have become available after that, and our patients with lung cancer are doing much better. With these words, I think I'll invite Dr. Chalvi to say a few words, and then Dr. Govind Babu to go for his talk. So we have made big progress in lung cancer, and that is something very, really good. Thank you so much. Dr. Chalvi, please, if you can. Hello.
Ma'am, you need to unmute, ma'am.
Yeah, good evening, everyone, and I thank the organizers for giving me this opportunity, and it will be nice to hear what Dr. Govind Babu has to talk. And I think the students are going to have a nice time with this session. Thank you very much for the opportunity, and Dr. Govind Babu can start this talk now. Thank you.
Thank you for that kind introduction. So I will start sharing my screen. And so as Dr. Dovell told you that he was one of the first person to ask me to talk on molecular biology of lung cancer when all that we knew was RAS and MYC genes in lung cancer. And from there, we have come a real long way. It was nice of him to remember that. In fact, I still have some of those slides, and I use them sometimes to actually patch in and show from where to where we have gone. So today I'm going to talk on two aspects of non-small cell lung cancer. The first one will be about non-oncogene addicted non-small cell lung cancer, and the next one will be on oncogene addicted lung cancer. So greetings to you from Bangalore and many other parts of India. So this is going to be the outline. I'll give a brief introduction to the disease as such, talk a little bit about the evolution of chemotherapy, the concept of maintenance, and how we have progressed in increasing the number of lines of chemotherapy that we give to our patient, ultimately increasing the outcomes and the survival, and try and conclude meaningfully. So this is just to talk about the evolution of death rates in males, and this is SEER data from 1930 to almost the beginning of this century. And as you can see, the red line is for the lung cancer in men, and you can see that it's exponentially increased from 1930, and around 1990s it's shown a dip. And epidemiological studies have clearly shown that this is because of its relation to smoking, and it's dipping because men have realized this and decreased smoking. Whereas if you look at the same thing in women, you can see that they picked up the habit of smoking later, but they've continued to smoke for longer periods of time. So it seems that the incidence and the death rates of lung cancer in women is increasing. I always thought women were a smarter lot than men, but I think they're driven by various other reasons to continue to smoke. So that is important for us to remember. Next is looking at the incidence and mortality in lung cancer. If you have seen the mortality of lung cancer, it is very similar to the incidence, which means that the mortality of lung cancer is very high. And this is just to show you that the estimated cancer deaths of prostate, pancreas, breast, and colon put together equals that of lung cancer. So that is how big a problem we have with lung cancer. Now, this is just to look at how the therapeutic landscape has changed today when we are talking about stage 4 lung cancer. And this is just representing figuratively that we now today know that there are a lot of driver mutations that are there, and that has specific therapy that can be given, of which I will talk to you in the next talk. But by and large, the rest of the people, we need to look at chemotherapy for them. And this is again to show you that a large amount of patients have to be resorted to chemotherapy in spite of immunotherapy coming in, and therefore it's important that we look at non-small cell lung cancer in that context, that a large population of them will require chemotherapy, for which we need to look at the histology. So this is to see the scope of systemic chemotherapy in non-small cell lung cancer. And we know that a small percentage have resectable disease, a large proportion have locally advanced, and a very large proportion come with metastatic disease. But even if they come with very early disease that is resectable, 50% of them over time relapse. In locally advanced disease, in spite of so-called curative therapy, 80% of them relapse. So this is actually data from Francis Shepard way back in 1999, and the figures still continue to be more or less very similar. So therefore, there's a huge potential number of candidates who are eligible to get systemic therapy, and therefore the progress that's happened in systemic therapy for metastatic non-small cell lung cancer. This is again to show you that about 25 to 30% of non-small cell lung cancer undergo curative surgery. The intent is curative, of course, stage 1 to 3A, but almost 70% of them come back with systemic relapse. So this is one of the first papers that was published way back in 1995 in British Medical Journal to show that, in fact, systemic chemotherapy was beneficial as compared to best supportive care alone, because till that time, that was the best thing that these patients would get. And this actually showed that there was a survival advantage. And before this chemotherapy came in, the median survival of metastatic non-small cell lung cancer was in the order of 3 to 4 months. With the advent of use of platinum-based chemotherapy, that doubled. But from there, we have come really a long way with the newer drugs coming in. So, as Dr. Dole was telling you, this is 1990, that is when I got into medical oncology. And at that point of time, we had cisplat, carboplat, and as he said, we were using cyclophosphamide. But soon we have a lot more drugs, so that I will show you as we go along. So this is the progress that we made pretty rapidly, that we suddenly had second and third generation chemotherapy agents, and therefore this landmark study was done, the ECOG 1594, to compare these third generation chemotherapy drugs with a platinum backbone. And what they hoped was to try and show that one of them would be superior to the other. And as you see here, this was the combination of the various third generation chemotherapy drugs with the platinum being the backbone. But to everybody's surprise, the outcome, the overall survival for all these four combinations were very, very similar, as you can see from this graph. And this was published in New England Journal in 2002. So we didn't have any superior doublet to choose from these four that were studied. So then came the thing that, is it important to look at the pathologic subtype before planning treatment? And this important answer for this was yes. So retrospective analysis over 25 years of literature was looked at, and 10 studies showed weak association of histology and chemotherapy. It seemed that chemotherapy was better in non-squamous. In 1980, this combination of cisplat plus VP16 versus 4 drugs was studied in both squamous and adenocarcinoma, and this showed that there was some advantage of using 4 drugs in terms of response rates. So this was one of the first papers that was published to show an association of histology with the response to chemotherapy. Then came in this drug called pemetrexed. All of you are really familiar with it because this is a very old drug now. When it first came, our excitement knew no bounds. This was the study that actually proved that this drug was in fact very useful, the JMDB study. And as you can see, the randomization was between cisplat, pemetrexed, and cisplat and gemcitabine. And what came out of this was that the overall survival for the two arms was very, very similar. Again, telling us that pemetrexed in combination with platinum was just as good as gemcitabine with platinum. But since they had included the looking for the histology, what came out was that in non-squamous, pemetrexed plus cisplatinum was better than gemcitabine plus cisplatinum, whereas in squamous, the combination of gemcitabine was better. And again, this is a retrospective analysis of comparing pemetrexed versus docetaxel, just to show you that pemetrexed was a less toxic drug as compared to docetaxel. Now, why was this so? This again was because of elegant studies done on the genes in these tumors, which looked at thymidylate synthetase expression, because that is the target for pemetrexed. And they showed that in adenocarcinomas, the level of thymidylate synthetase was low, and the therapeutic doses of pemetrexed that we use was adequate enough to suppress this thymidylate synthetase, whereas in squamous cell carcinomas and small cell lung cancer, this level was very high, and in the therapeutic doses of pemetrexed that we use, it was not sufficient enough to suppress this particular enzyme to bring about therapeutic benefit. So this was a nice proof of concept for us as to why pemetrexed is better. So again, they looked at histology with respect to the other drugs that we had, antimicrotubule or gemcitabine based, and they did not find any great association there. Next, we understood that there was something called the angiogenic switch happening in most solid tumors, and especially so in lung cancer. And what this concept is that when the tumors are small, about 1 to 2 millimeters, their relatively non-vascular and they remain dormant. But as they start growing larger, they need new blood vessels because they need nourishment, and that increases the metastatic potential. And to self-sustain the growth of this tumor, the tumor produces several cytokines to enhance angiogenesis. VEGF is one of the most important and well-characterized one. So understanding this pathway, people started to see if we can target this pathway. And what happened from was the study called the E4599 study, which had paclitaxel carboplatin with or without bevacizumab, which is a VEGF monoclonal antibody. And there are two studies here which I have summarized here, one with carboplatin paclitaxel and other with gemcitabine paclitaxel, and combination randomized with bevacizumab. And both these studies actually showed that there is an advantage in terms of adding bevacizumab to block the proof that angiogenesis is an important driver for non-small cell lung cancer. So what about elderly? Again, these are 5 studies which have been published to show that even in the elderly, this particular concept of blocking angiogenesis is in fact good, and it does not carry any increased toxicity even in the elderly group. So what does the ESMO guidelines tell us? That the combination of bevacizumab and other platinum-based chemotherapies may be offered in absence of contraindications in those patients who are eligible to get this particular combination, because this has shown improved overall survival and progression-free survival when this combination is used. So that is the consensus from the ESMO. The other one is about squamous cell carcinomas, which the numbers are gradually decreasing. When we started practicing, this used to be pretty high. Now it has come down. Why has this come down is a debate for another day. So it has been said that treating squamous cell carcinomas is an unmet need, and this is as per this press release and publication in Biotrends Research. So to target this, there was a drug that came in called Abraxane or albumin-bound paclitaxel, which is today considered a targeted chemotherapy. And this is a slide to tell you that why this drug is considered a targeted chemotherapy, because it seems to have its activity because there is high spark expression in the squamous cell carcinoma. And this was a study which was a phase 3 randomized study showing you that the paclitaxel with carboplatin was compared with paclitaxel, the conventional one, with carboplatin. A good number of patients, over 1,000, randomized to these two arms. And again, they looked at the histology of these patients. And as you can see here, the response in all histologies was definitely better in the arm that got nab-paclitaxel, whether it was independent radiological review or the investigator assessment. And again, to look at the objective response by histology, a little more clearer here, you can see that the responses were much higher in the squamous cell carcinoma, between 37 to 41%, as compared to non-squamous, where it was between 26 to 37%. So again, showing you that the proof of concept that nab-paclitaxel was an important drug when you're treating squamous cell carcinomas. Again, this is summarizing the whole thing, showing you the advantage of pemetrexed in squamous cell carcinomas. The other drug that was found to be useful was cetuximab, and the data came in from the FLEX study, which showed that adding cetuximab to chemotherapy increased the median overall survival of 11.3 months versus 10.1 months, with a 1-year survival of 47 versus 42%. And this was published in 2008 in ASCO. And in terms of response rate, progression-free survival, and treatment time to treatment failure, on all these parameters, cetuximab seemed to have an edge over not giving cetuximab. The other monoclonal antibody that came in was necitumumab, which was a IgG1 monoclonal antibody to EGFR, and this was in fact further studied in combination with chemotherapy, and the study was called SQUIRE. which combined cisplatinum gemcitabine in the squamous cell carcinomas. As I showed you, in the squamous cell as compared to non-squamous, gemcitabine had a better effect, and that's why the concept of using gemcitabine for squamous cell. And the ESMO guidelines for this particular monoclonal antibody did not take off very well those days, but it still continues to be there in the guidelines that addition of necitumumab to cisplatin and gemcitabine, although has not been adopted as a standard, it did show some advantage, and it can be still used carefully. And now there are studies which are coming up to actually revive this for further studies. So another monoclonal antibody from our own city, nimatuzumab, and this was a study that we conducted across several cities in India, including Dr. Doublet. And nimatuzumab, as you all know, is a humanized monoclonal antibody, and this is a structure for you. And we randomized the patients between docetaxel and carboplatin versus docetaxel, carboplatin, and nimatuzumab. This was the time when this was conceptualized and studied. We did not have enough data about EGFR and EGFR blockers, so these were very old days. And we did show that the response rates to the arm that got nimatuzumab with chemotherapy was 60%, as against 39% for the arm that did not get nimatuzumab. In fact, we have published this in June 2014 in Oncotargets. Of course, it's still not extensively used, but I do find it a useful drug in squamous cell carcinomas along with nab-paclitaxel. So squamous cell continues to be an unmet need. We are looking at gemcitabine platinum doublets. Anti-angiogenic strategies seem too toxic here. Cetuximab from the FLIX study has some advantage. Necitumumab seems to be having guarded approval. And of course, if we are talking about our context, I have shown you data with nimatuzumab. And newer strategies needs to be developed. And one of them that's coming, I will talk to you a little later. So that was first line for you. What about second line therapy? For a long time, we were not even talking about second line systemic therapy for our lung cancer patients. But this is happening today because our patients are living longer because we have better drugs. And for a long time, docetaxel remained the standard second line as a single agent because that did show an overall survival advantage as compared to best supportive care in second line, which was the similar case when we used cisplatinum-based chemotherapy in the first line. And then we had pemetrexed, and pemetrexed became a more favorable drug because of the lower toxicity as compared to docetaxel. Now we have several other drugs that have jumped into the second line. One of them is nintedanib, which is an anti-VEGF blocker, and this is shown an advantage when it's combined with docetaxel. This is the chart to show you the overall survival advantage for this combination of nintedanib plus docetaxel. So what does ESMO guidelines say? That this combination is a treatment option for patients with adenocarcinoma who are progressing after previous chemotherapy or even immunotherapy. And again, who should get this is dependent on various other factors based on how they were responding to first line, how rapidly they progressed, whether they can wait for some time till immunotherapy can kick in or not. The other drug that's been in the second line is ramucirumab, which is again a monoclonal antibody. And this is the study called REVEL, which actually proved that adding ramucirumab with docetaxel versus docetaxel is beneficial. And this is to show you the PFS and the OS advantage of using ramucirumab. So the ESMO guidelines again says that docetaxel plus ramucirumab is a treatment option for patients with non-small cell lung cancer progressing after again either chemotherapy or immunotherapy, and of course with a performance status of 0 to 2. What about the role of TKIs in unselected non-small cell lung cancer patients? So for a long time, these drugs were used, and there is some evidence to show that these patients may benefit, but as of date, these are not really great recommendations. If and when they do not are not eligible to get chemotherapy, maybe we can try based on all these studies that have shown you some sort of benefit from them. So what does ESMO guideline say? That erlotinib represents a potential second or third line for those patients who are not suitable for the other therapies, which is second line chemotherapy or immunotherapy, in patients whose EGFR status is unknown or even wild type EGFR. So the concept of maintenance chemotherapy, the concept is that you use uninterrupted continuation of the therapies for these patients in those people who have not progressed after first line. And the key considerations for this is histology, the residual toxicity of first line, response to platinum doublets, performance status, and of course, the patient preference. So in maintenance, we have two categories, continuation or switch maintenance. And what is this paradigm of maintenance therapy? So this is again diagrammatically to show you that those patients who get first line chemotherapy, who have either CR, PR or stable disease, if they have a break from treatment and once they progress, we were looking at giving them second and further lines of treatment. And this was considered important because the patients would have a holiday from the toxicities of this chemotherapy. But this does not seem to be a good therapeutic concept because of various reasons. And one of them is that up to 50% of these patients would not be eligible for further therapy when they showed progression. And therefore, they would not get an option of a second line. And this is to show you from various studies that almost all the studies showed that 50% of these patients did not receive second line chemotherapy. And as you can see, there are quite a number of studies which showed that. So this is again to tell you that 46% of these people did not receive second line because 17% died before they made a decision, and 29% only could get best supportive care because of poor performance status, other comorbidities, etc. And this is data in the real world collected from 306 European Union physicians. So the concept came in that the maintenance of chemotherapy in these patients. So what you would do is we do not give a break. We continue with this maintenance therapy because then you are delaying the progression of this disease, and more of these patients would not be able to get second line chemotherapy would benefit from this maintenance chemotherapy, and you're increasing the overall survival for these patients. So the key objectives were to delay disease progression, importantly prevent symptom deterioration, maintain performance status so that they can fit in to get further chemotherapy, increase overall survival, and most important because we did have access to much safer chemotherapy drugs. So chemotherapy in the elderly is an important issue because most of our patients with lung cancer are elderly, and many of the trials do not take these patients who are very elderly into the clinical trials, and therefore we may not be able to have good data for this subset of patients. So it's important because in the elderly we need to look at the various organ systems, which I have put them all together here, because there is an interplay of all these comorbidities. There is a decrease in drug metabolism, there's a problem with organ reserve, and many of them have been smokers. They would have had underlying lung problems. So all these need to be considered before you look at giving chemotherapy for the elderly. Now, I told you about second line, I told you about maintenance, and this is a nice paper talking about the need of third line chemotherapy. So this was really unheard of some years ago, and this again is by Dr. Frances Shepard, and she said that for non-small cell lung cancer, no standard definition for disease refractoriness to platinum and docetaxel, and clinical definition of third line depends on how much these patients have tolerated the previous therapies and how fit they are to get the third line therapy, and most often this is going to be a single agent therapy. And does this merit use of third line? And this is a study from 43 patients published by Massarelli, again showing you that the objective response, the median survival is there, although in single digits. But when these patients were asked whether they would like to take chemotherapy, even in these third line, 68% of these patients who had already received platinum and had experienced what the toxicity is, they said that they would choose chemotherapy compared to best supportive care if their symptoms substantially decreased, even if survival was not prolonged. So I think this drives in the point that as medical oncologists, we should not be taking decisions for the patient. We need to involve the patient in the decision making, and this is what we call today as participatory medicine. So this is sort of a summary slide. If you remember the first slide I showed you where I started in 1990, from there if you see we have so many drugs that have come in, and our whole concept of treating metastatic non-small cell lung cancer has so totally revolutionized. We have understood angiogenesis. We have several different drugs to target all these. And if you see here, from a dismal 2 to 4 months of median survival in 1970s, we have come a long way today. Even with the systemic chemotherapy agents, we are talking in excess of 24 months median survival for these patients. I think that is a huge step, and I'm sure Dr. Dovel, as he made his beginning remarks, I'm sure we all have seen this, and many of you are still very young because you wouldn't really realize what we had to face those days. With that, I think I will stop this part of the talk, and thank you very much. Should I continue with the next one, or anybody wants to make a remark?
I think you can continue with that.
Okay.
And at the end of the session, we can have interaction.
Okay. I'll just share my screen 1 minute. Okay, can you see my slides now?
No, sir.
Now?
No, sir. So you need to first
I
stop
did
sharing
that.
it.
Yeah. Okay.
Yeah.
Yes.
Okay. So now that you have heard about the systemic chemotherapy, I'm going to talk to you about treating mutation-driven non-small cell lung cancers. So the outline again is going to be some introduction. Initially, I'll talk about the common pathways that we know, EGFR, AL cross, and then go into the rarer ones, which will include RAF, MET, RET, TKRK, and HER2, and again some conclusions. Again, to start off, just to remind you how we have progressed. So what has happened very beautifully in lung cancer is that we have had several advances in molecular biology and the techniques. And therefore, today we know that from a normal bronchoepithelial cell, for it to become a lung cancer cell, there is an extensive interplay of dominant oncogenes, tumor suppressor genes, and also housekeeping genes. And there are several steps that are involved, and we have understood each one of them. Again, to show you in a different form, from the normal epithelium into invasive cancer, we have hyperplasia, dysplasia, carcinoma, and C2. And each one of these steps have been very nicely configured today in terms of the genetic changes that are there. And why is this important? Because each one of them can be used as a therapeutic target. I'm sure you can recognize who this is. This is Mona Lisa. So that was what lung cancer was when I started treating lung cancer. It was one single entity. But if you zoom in, you can see that this is a collage of several different pictures put together, and that's what non-small cell lung cancer today is. So 1984 to 2003, this was the pie of the non-small cell lung cancer. We knew that there was something called KRAS, which I told you I spoke about in Dr. Dowell's meeting, INMIC and KRAS. In 2004, we knew about EGFR. In 2009, half this pie had slices where we knew a driver mutation existing. Come 2015, more than half of this pie is now have slices for driver mutations. How much more increase? No more a single disease. This was then histology-based subtyping. I told you when I spoke about chemotherapy, and this is what it is today, and this is what I'm going to talk to you about. So that was 2016. In 2017, the taxonomy is this complex. We first look at the histology, then we look at the TPS score, and then we look at the targetable mutation. And then we can have a combination of these mutations plus TPS, and accordingly we plan whether these patients will get chemotherapy, targeted therapy, checkpoint inhibitors, or combinations of several things. So this is what has become important, and this is the new taxonomy for non-small cell lung cancer today. So this is some consensus statement which says that testing for EGFR, ALK, ROS1, MET, BRAF, V600E, NTRK, HER2, and RET, MET exon 16, 14 are indicated in all non-squamous non-small cell lung cancer. And it is encouraged that you do a broad spectrum NGS to detect all these upfront. And for squamous who are never or light smokers, again, you should do the same. In fact, we have data to show that even in smoking squamous, there can be a EGFR mutation. And when you're waiting for this, you also do PD-L1 because that has become an important target, and then accordingly act on what comes out of this. So let me start with the EGFR. This is a cartoon to just show you how the EGFR signal transduction occurs, and this is overactive in tumor cells. So this is a ligand that binds to the extracellular domain of the receptor, which leads to dimerization. This is the intracellular domain where the tyrosine kinase is located. That leads to downstream signaling, which acts on the nucleus and produces second messengers, which make the tumor cell have all the advantages in terms of proliferation, resistance to the therapies that we offer, having a survival advantage, reduce angiogenesis, and metastasis. So understanding this, we have now come with the concept that we can use this tyrosine kinase inhibitors to block this intracellular domain, and by using this, all the downstream signaling is stopped, and the advantages that the tumor cell has is lost, and that leads to apoptosis of these tumor cells. So there are various strategies for inhibiting this signal transduction. The most extensive one is the tyrosine kinase inhibitors, which are oral drugs. We also have monoclonal antibodies. I will just, I've actually shown you a little bit of it in terms of the monoclonal antibodies like the cetuximab, etc. So that is again targeting EGFR. Dr. Dowell, if you remember, mentioned about the ISIL study, which was the first study looking at geftinib, which was the tyrosine kinase inhibitor. And there were several centers across India. I was also one of the PIs from our hospital, Kidwai. And the study was comparing geftinib versus placebo in the second line or the third line of after the chemotherapy. Of course, we just knew that this was a tyrosine kinase inhibitor. We didn't know enough about the pathway or the mutations. So what came out of this was that geftinib showed an advantage in terms of those people who were never smokers versus ever smokers. It was better in Asian ethnicity and women as well. We did not know why this was, and therefore we always talk about bench to bedside because what is done in the lab comes to the bedside ultimately. But here, this is a concept of bedside to bench. After astutely looking at these patients and finding out why these people were behaving differently, they went back to the bench. Then they understood that this was because of the EGFR mutations that were there. And surprisingly, again, this told us that although this study was negative and gefitinib was never approved, we had 91 patients from India, and we really saw that all our patients were doing well, as Dr. Doublet told, one of his longest survivors. And again, from this study, we realized that EGFR mutations are higher in the Southeast Asian population and the Indians, whereas very low in Caucasians. So that was a nice thing that came out of this study. And soon enough, followed this IPAS study from Dr. Tony Mock, again showing that gefitinib was superior to chemotherapy in the EGFR mutated patients in the first line. This is all chemo-naive patients. And this is what we understood, that there were EGFR mutations and the 4 exons, which is everyday knowledge, and today most of us follow this. So this is one of our patients, was 63 years old lady. This is the chest X-ray for you. She was EGFR mutant, and within 2 months of gefitinib, this is the response that she has. We soon had the second generation EGFR TKI, that is afatinib, but all the studies of gefitinib, erlotinib, or afatinib showed that ultimately these patients progress, and with a median progression-free survival of 18 to 14 months. And all these 3 drugs did not show any overall survival advantage. So we started looking at why these patients were progressing, and ultimate was the rebiopsy to look at the mutation or the resistance pathways. And this initial study of about 37 patients gave us an idea that T790M mutation was seen in almost 49 patients and 49% of patients, and this was the resistance pathway that was implicated. There were several others, as I've shown you here. And the next study with a little higher number of patients actually showed that the T790M mutation was even higher, up to 63%. And therefore, this drug was designed to target this mutation, the osimertinib. And this was one of the first studies which were published to look at the response rates of the T790M positive cohort. And as you can see here, other than just 4 patients who did not show response, everybody had a response. So immediately came the study called FLORA, which is looking at osimertinib in the first line setting. So till now, it was used in the second line setting when there was a detected T790M mutation. And this study compared osimertinib versus standard of care or any TKI that the patient, that the physician chose to give this patient. So this was the PFS advantage for osimertinib, and the initial interim overall survival was actually presented when there were 25% data maturity, and that did show an advantage. But then people didn't want to accept it because it was just 25% mature. And then Dr. Suresh Ramalingam presented this final data in ESMO 2019, showing that the median overall survival for osimertinib was 38.6 months versus 31.8 months for the other TKI. And this is the very recent data published in NEJM in 2020, showing you that at 1 year, 2 year, and 3 year time periods, the overall survival is holding on for osimertinib, and you can see the 2 curves very nicely separating even at 3 years. So they looked at brain metastasis and the activity in the study, and they showed that osimertinib was definitely useful in tackling brain metastasis. And this is to tell you that the CNS progression occurred in 6% for the people who got osimertinib, as against 15% for those patients who got the first or second generation TKI. But as with the first generation TKI, again with osimertinib, we have had resistance coming in, and this is one of the first papers that was published in 2017, showing you the resistance mechanisms, and one of the most important one is the C797S mutation, and of course 50% of them lose the T790M mutation, and several other mutations that are shown here. And this becomes even more important because of the subsequent pathway targeting that I'm going to talk about. So can we improve upon the use of these EGFR TKIs. And to look at this, they have tried to combine it with anti-angiogenic therapy. And this is a study called RELAY. If you remember ramucirumab, I spoke to you in the earlier talk. This is combining with erlotinib versus erlotinib. And this is to show you the progression-free survival, which was their primary endpoint. And the one-year PFS is 71.9% versus 50.7% for those who did not get ramucirumab. And the other one is combining bevacizumab, which is again a very old drug which we all know today. And this study was a Japanese study which was published in Lancet last year. And the primary endpoint was a progression-free survival, which this study met. But in terms of overall survival, there was no advantage. This is the other study from our own country, geftinib combined with pemetrexed versus geftinib alone. And this was presented at ASCO last year. Again, they showed an overall survival advantage. In fact, from Kidwai, Dr. Anthony has just finished this similar study, and he's ready for publication. We've also looked at combining minocycline with geftinib. That is another concept that we wanted to prove, and again, that has shown some advantage. And again, Dr. Anthony is going to publish that data as well. So I think we have several ways of trying to improve upon the EGFR TKIs, as I've shown you here. Yes, the other one which I told you about is the nimotuzumab. I thought I'll just re-show it again here because there's a monoclonal antibody blocking the EGFR pathway. So what about chemotherapy plus immuno-oncology drugs for EGFR mutant patients? And for this, we have data from IM Power 150, and this was very nicely discussed in the World Lung Congress last year. And this was a study that combined chemotherapy plus bevacizumab plus atezolizumab, and this had a cohort of patients who had progressed on EGFR TKIs. And as you can see here, although they had progressed on EGFR TKIs, they did show response to this combination of IO plus anti-angiogenic drug. In fact, this is the only study that has looked at immuno-oncology drugs in this setting. So some of the emerging novel options for EGFR TKIs, and these are slides I've actually borrowed very recently from Dr. Suresh Ramalingam. And this is about a compound which still has only a number, U31402. And this is the activity across diverse EGFR resistant mechanisms. And as you can see here, this is EGFR activating mutations that are newer ones, BRAF mutations, PI3K mutations, and increase in copy number. And to all these, this drug seems to have a benefit. So they have had PR, stable disease, and some responses. So this is a drug we need to look out for. Other one is a monoclonal antibody called amivantamab, and this is an anti-EGFR and MET bispecific monoclonal antibody, and this was showing a response of 30%. And what was the mutation that was seen? The primary was in the exon 20, 19, and 20, and these are the mutations that were seen, deletions and insertions, and the acquired mutations of T790M, MET amplification, and C797S. And as you can see, more than half the patients have shown good tumor regression. So this is again a proof of concept that you can have a bispecific monoclonal antibody and target different pathways. The other one is exon 20 insertion, which is seen in about 50%, in about 5% of EGFR mutant patients. And this is a resistant mutation that is there. And there are several mutations that are shown. Some of them are insertions, and some of them are point mutations. And for this, we have this drug called mobocertinib, which was a number till recently. And again, as you can see, there was just one patient who had progressive disease. Almost everybody has some form of response that is seen. So this again is showing you that we have several drugs that are now coming in. Again, amivantamab, which I spoke to you about, its activity in exon 20 mutations, again, good response rates. This was again presented recently in ASCO 2020, and these are drugs that we need to look out for. The use of osimertinib in exon 20 insertion, and again, This is a small cohort. The usual dose that we use is 80 milligrams. In fact, this study used 160 milligrams, trying to see if they can have benefit. And as you can see here, using a higher dose, in fact, is beneficial with really tolerable side effects. So this is another option that we have. Since I'm talking about EGFR TKIs, I will complete the adjuvant therapy as well. And this is the ADORA trial, which looked at use of osimertinib in adjuvant setting. And this is the initial data for you, the primary endpoint, which was PFS. You can see that the two curves are so grossly diverging. And that is a good thing for us to know. And it seemed to be working in all subgroups that they studied, although the response was not as good as others in stage 1B. But for all other subgroups, it did show a benefit. So with that, let me go on to the next target, that is the ALK, which is the EML4 ALK translocation. And this is just diagrammatically showing you the same. And it seems to be about 5%, and it seems to be more in the younger people, more in women, and more in never smokers. Although universally it is 5%, in these subset of patients it can be a little higher. So this is detected by the break apart fish, as we all know. And the first drug that came in was ceritinib. This was again a designer drug which blocks this particular pocket. And this was the first study, the profile study, which was showing you the, no, this is not profile, this was the phase 2 study, which actually showed the use of targeting this pathway. And this is a waterfall plot showing you that there was an overall response rates of 57% and a disease control rate of 87%. And these were the PET CT scans which showed that within 2 cycles there was a rapid response. This is a CT scan, this is the PET scan. You can see that there was very good response just at 14 days of therapy. All the lit up lesions on this side have disappeared in 14 days. So it is a proof of concept that ALK inhibitors can work really rapidly. And this was the profile 1014 study, which was a phase 3 study comparing crizotinib versus chemotherapy, which was the standard till that point of time. And as you can see here, there's a huge divergence of these two curves, and the median overall survival was 10.9 months versus 7 months. From this, crizotinib was given approval in the first line for ALK positive patients. This was the final overall survival, again showing you advantage. Now we have several of these TKIs that have come in, and this is again showing you that we have first line TKIs, crizotinib, ceritinib, alectinib, and brigatinib. Once they progress, we look at second line, third line, and subsequently chemotherapy. We have these newer ones coming in as well. And this was the study which looked at the second generation ALK inhibitor, alectinib, compared to crizotinib. And as you can see here, there was a distinct advantage here. And this is the ALEC study in the first line, comparing alectinib versus crizotinib, again showing you the progression-free survival, which is a difference of almost 24 months. Continuing with the same theme of resistance as in the EGFR, we do see resistant pathways that come up with the ALK pathway as well. And this is sort of summarizing the whole thing, that these patients do develop resistance mechanisms. So this is to show you that we had crizotinib first, then we came with ceritinib, then we had alectinib, then we have brigatinib, and the most recent one is lorlatinib. And there are 2 others which I will talk about. So today, for targeting ALK pathway, we lost the choice. So we need to look at how these outcomes are in the first line. Are they same or are they different? This is for crizotinib, this is for ceritinib, and this is for alectinib. Putting all of them together, alectinib and brigatinib from these 3 studies, showing you that there is a distinct advantage of using the newer generation ALK inhibitors. What is important is looking at the intracranial activity, because many of these ALK positive patients come with de novo cerebral metastasis, or while they are on therapy, they fail with intracranial metastasis. So we need to look at the intracranial penetration of these drugs, because once they develop the intracranial metastasis, all that we can do is give them cranial radiation. So we are looking at intracranial control with these drugs, and as you can see this graph with crizotinib, over time the failure rate in the intracranial disease goes increasing. And with the radiation, the dreaded radiation necrosis is a problem we all need to face. So if we can try and use drugs and delay this cranial radiation, we are able to take care of this radiation necrosis and prevent the subsequent morbidity and mortality for these patients. So this is showing you the intracranial activity of alectinib versus brigatinib, and as you can see here, there is good intracranial activity for both of them, and this is sort of summarizing all the TKI, ALK TKIs that we have, looking at their intracranial response, whether de novo or after some lines of chemotherapy or otherwise. And as you can see here, brigatinib seems to have the most activity intracranial. Of course, their activity is different, so also their toxicities. So when you choose a drug, you need to look at what toxicity you're going to give your patient, and subsequently look at the comorbidities and choose your drug. So first line ALK TKIs, we have different studies as I've shown you here. Crizotinib was the first one, then came in ceritinib, then alectinib, and then brigatinib. And now we have lorlatinib and ensatinib, which have come in, and these are the studies that are there. So looking again as to how we need to sequence them is here, and once they have second line failure, we look at lorlatinib or brigatinib, and the thing is that we are trying to see how we can delay the onset of these resistance mechanisms by using much more potent ALK inhibitors upfront. And again, this is to do that the different ALK inhibitors that you use, the resistance pathways are different, and this becomes important for you to choose a drug, because some ALK inhibitors are not active against some mutations. And this is a nice table that has been made to tell us how to choose, because I'm sure none of us can remember all this. So we need to look at this table to see what the mutation is and which drug we can use and sequence them. Of course, these mutation analyses are not easily available right now for clinical use, but I'm sure this is going to happen because we are now using more and more active agents to block this pathway. So the drug that is coming is lorlatinib to target the ALK TKI resistance, and this is a general picture talking about its activity after one line or two lines of ALK TKIs. This is a pooled analysis of several studies, again showing you that this drug has good activity against several mutations. So, like I said, we are trying to take care of the intracranial disease because we want to avoid radiation to the brain as long as possible. This is important because many of our patients have today lived long. In fact, one of my patients on a study has finished 5 years recently with intracranial metastasis. So if we had targeted his intracranial metastasis with radiation, you can imagine what the problems he would have had. So just with this ALK inhibitor, without cranial radiation, he is leading a normal life. So with lorlatinib, again, the theme of recurrent resistance coming in is documented, and this is again comparing the analysis of ctDNA or the tumor tissue. As we understand, the tumor tissue is always not easy to get, and therefore this was a study to see how concordant or discordant ctDNA analysis was against the tumor tissue. And if you look at these two pie charts, they look very similar. So you can either use ctDNA or tumor tissue to analyze the mutation resistance pathways. So this is sort of talking about how you sequence them. If you use crizotinib, your second line depends on what you can use. If you used the second generation upfront, then you have the newer drugs that come in, and ultimately you're going to use chemotherapy. So what we are looking at is delaying the use of chemotherapy in these patients, giving them much safer drugs upfront, prolonging their survival, so ultimately decreasing the chance of irradiating their intracranial disease to the very long period of time. Now, this is a study which was published, not a study, it was a case report talking about response to crizotinib after the patient has progressed on lorlatinib. So this again undermines the importance of serially addressing and looking at the mutation analysis, so you can still go back to your first generation ALK inhibitor if there is a pathway that can be targeted even after using lorlatinib. The other thing we always talk about is concomitant EGFR and ALK mutations, and this is now coming up in a important way because earlier we were not seeing too many of them, and now what is said that if you find two of these, you need to look at the metastatic site and the primary site, and because each site may be driven by a different pathway, and what is recommended is you look at the phosphorylation of these pathways and accordingly choose your drug. But there is still no consensus on how to use these two targeted agents because the number of cases are very, very limited. So with that, let's go on to the ROS pathway. This is about 1% of all non-small cell lung cancer, and the first drug that was used was crizotinib. This is showing you the progression-free survival and the antitumor activity. This was again published in 2019. So this is very new updated data for you. And again, this is specifically looking at East Asian patients because these patients seem to be doing better on ALK inhibitors. Again, the lorlatinib in these ROS1 mutated patients in the TKI naive and those who have got crizotinib, as you can see, the activity of lorlatinib seems to be much better in those patients who have not been targeted with any other drug earlier, 62% versus 35%. The other new drug is repotrectinib, and this is the activity in ROS positive patients who are TKI naive and showing you an impressive response of 82%. And this is in pre-treated, this is slightly lower, about 40%. And this is again looking at from another subset where they were looking at TRK mutations and ALK study, again showing you that in these patients, use of these newer agents do have benefit. Entrectinib in ROS1 fusion, TKI naive, you can see that the responses are even higher here as compared to lorlatinib. So again, just to show you crizotinib data of PFS and OS and entrectinib, you can clearly see the difference in the responses in terms of PFS and OS with these newer agents. Then coming to the BRAF, this is again a very small percentage and a very specific mutation that we're interested in lung is V600E. It's also important to remember that the mutations of BRAF are different based on the stages of the disease. And why is this important? Because these drugs are eventually going to move into early lines of therapy, even in early stages. So it becomes important that we look at these specific mutations. And this is one of the first reports that were published in 2013 talking about dramatic responses induced by vemurafenib. But soon we learned that just blocking the BRAF pathway is not enough because there's a rebound of the other pathway, that is a MEK pathway, and therefore we need to have a dual blockade of BRAF and MEK pathway. And today we have these two drugs, dabrafenib and vemurafenib, or trametinib and cobimetinib, to block these two pathways simultaneously so that you are taking care of the resistance pathway and overdrive by that pathway at the same time. Other one we are talking about today is MET exon 14 alteration, and this again is seen in about 3% of adenocarcinomas, 2% of squamous, and if you have a histology of sarcomatoid, it can be as high as 20%. And the recommended method for looking at it is a next generation sequencing. And this is the activity of crizotinib in this particular group of patients. This is one of the first cohort of 16 patients, and as you can see, everybody have shown a response. Now we have, like the other pathways, several drugs, and I have just shown you the waterfall plot of 4 of these agents: capmatinib, crizotinib, capmatinib in second and third line, tepotinib in first and third line, crizotinib first and third line, and capmatinib in the first line. And as you can see, these waterfall plots look very, very similar, and therefore we have competing agents at this level for this pathway. So the MET tyrosine kinase inhibitors are two types, type 1 and 2, and I have divided them and shown you here. We need to remember this because they may be non-cross resistant, and after using type 1 you can go on to the type 2. The other pathway we are now looking at targeting is RET. Again, this is seen in about 1% of non-small cell lung cancer. The other tumor types, as you know, is the medullary carcinoma thyroid, papillary carcinoma thyroid. And these are the initial set of drugs that were used: cabozantinib, vandetanib, lenvatinib, and alectinib. And those are today considered old RET inhibitors because we have newer ones because these are much more active. And cabozantinib has a response rate of 28%. And the two new ones are selpercatinib and pralsetinib. And as you can see, the response rates are 85 to 65%. So these are newer agents, and these have just come in. Again, these were presented in ASCO 2020. So the other pathway that we are looking at is NTRK, and this pathway is tissue agnostic in that they are overactive or mutated in several types of tumors. And as I've shown you here, in the adults and the children, they're different. Although they are rare, this is a study of about 11,000 patients, and they had about 0.21% of these mutations seen in these. And again, larotrectinib is the drug that was first used, and as you can see in this waterfall plot, this is responses across different tumor types, including lung, and as you can see, these are appreciable responses. So we now have entrectinib as well, and the responses that I've shown of these two drugs, 79% for larotrectinib, and entrectinib is 57%. So many of these drugs are tongue twisters. I hope they act the similar way on the tumor. And this is one of the first data that came in with entrectinib. And as you can see here, they have activity on NTRK pathway for ROS1 as well as ALK. So this seems to be an important drug because it has activity on several pathways at the same time. HER2, no, this is not a breast cancer talk. This is a mutation that is now detected in lung cancer. It's seen in about 1 to 2%. And this is a confusing picture as I've shown you here. There can be amplification of HER2 as demonstrated by ISH or NGS, mutation as demonstrated by sequencing or NGS, or overexpression as demonstrated by IHC. And the options that we have: chemotherapy, immunotherapy, TKIs, a number of them, and monoclonal antibodies, again a number of them, and several of these combinations. So this is data for you from TDM1, and although not as impressive as in breast, they do show responses. This is seen in IHC3+, and there is data for IHC2+ as well. And this is a group now called low expressors, and we are importantly looking at this because we have drugs that can target these low expressors as well. This is again a swimmer's plot showing you the responses for TDM1 on those patients who have had prior therapies for the same target. And again, a response rate of 44% is pretty good for these poor prognostic patients. The other drug, poziotinib, is again important in exon 20 insertion. This drug has actually not been followed up for development because of its toxicity, and many other drugs have taken its place today. This is a novel ADC that has come in, trastuzumab deruxtecan, and this is again, if you remember, like TDM1 and ADC, with a different chemotherapy drug, which is extecan derivative. And this is the response rates for this drug in the initial studies. Looking at HER2 targeting with osimertinib, is that possible? This is a paper that is published. This is a preclinical paper. This is so because the HER2 exon 20 insertions share structural analogy with the EGFR exon 20, and almost to 4 to 10% of all EGFR mutations in lung cancer. And because of this structural analogy, osimertinib can be used to target the HER2 exon 20 insertion, of course, at a higher dose, as I've shown you earlier, at 160 milligrams. So today we are looking at this pie, which shows so many slices that can be targeted. So it's important to remember that. And the best way to look at all this is by NGS. So, a word about KRAS. Till now, we had nothing, but for this KRAS mutation positive patients, today we have a drug. And this paper was presented by Dr. Ramaswamy Govindan. And this is for a specific mutation that is seen. And you can see that the response rates was pretty high, almost 68%. And this molecule is called AMG 510, and it's got a fast track approval in 2019 by FDA. And this is for the specific mutation. And as you can see, this was a small cohort, but very good responses with a disease control rate of 100%. So till now, we had nothing to target KRAS, and suddenly we have this drug. So as I said, our understanding of molecular biology and drug discovery has really jumped leaps and bounds, and we are really using this knowledge to help our patients better. So this is to show you how we have progressed in terms of outcomes with patient selection. Initially, like I told you, best supportive care, then we had chemotherapy, then we had clinical selection, then in terms of cytology or histology, and then came in the molecular selection. So in 2010 to 2020, the overall survival for these patients is in excess of 5 years, which from 2 to 4 months is, I think, a tremendous leap that has happened. So for 2020, the paradigm looks like this. This is updated in June 2020, how we do the various workup for our patients, and this is sort of summarized here. So with that, I think I will stop, and thank you very much.
Thank you, Dr. Govind Babu, for that elaborate, comprehensive presentation on both aspects of non-small cell lung cancer, that is on the driver mutations as well as the non-small cell lung cancer without driver mutations. And it's been really nice. You've taken down memory lane when we did DM and we didn't have many choice at all at that point. Now we have come a long way where you are expected to do NGS for all these patients and then get on to what can be done for the treatment. So you need discussion at that point. So trying to do NGS for all the patients wherever possible, that will be the order of the day. And yeah, I would like to ask you whether you're doing NGS for all your patients or you're doing only that EGFR, AL cross MET combinations?
Yeah, actually, when I was in Kidwai, we were running a project. So we were doing NGS for everybody. In fact, we were waiting for non-small cell lung cancer patients to come. So fortunately, we had funding to do that. Now that I'm in private, I try and tell most of them to get it done. But it's not possible in everybody, yes. Yeah. Because one is, if they can do the test, then whether they can afford the treatment. That is the next step we need to look at. So that becomes a hindrance for most of us.
Yeah, the
and
next
like you told, we have really progressed over time. I remember we used to do an FNAC, have that it is non-small cell lung cancer and treat. Today, if you do that, you're liable to be prosecuted. That's so we have come a long way from there. Yeah.
Someone has asked, role of ceritinib after crizotinib in ALK mutated non-small cell lung cancer.
Yeah, there is a role, but we have better ALK inhibitors today. There is data for ceritinib after crizotinib as well, but we have, like I said, we have many other ALK inhibitors today, and the intracranial activity is what we are looking at. Like I said, ceritinib also has a good intracranial activity, but if you compare the others, brigatinib, lorlatinib seem to have even better intracranial activity. So if they can, then that is the ideal thing.
Okay, and also the combinations of mutations are seen, like EGFR and ALK,
yeah,
and then ALK and MET.
Correct.
This I have seen a few patients.
Yeah,
so,
we have actually Yeah, correct. That's true. We have actually published 4 patients of ALK and EGFR together. So, in fact, we asked Dr. Ramaswamy Govindan and Dr. Suresh Ramalingam, how do you treat these patients? So, they said we still don't have any consensus. One of the things that I mentioned is they look at the phosphorylated levels of these targets, and based on that, you use it. Some of them are the opinion that you start with one and see how they respond, and some are of the opinion that you target both. So we still don't have a consensus. So here, I think one thing that is happening right now is looking at the ctDNA, quantifying the EGFR and the ALK. And if it seems to be more, you target them. But this is still preclinical, not for routine.
That seems to be an option, because we treated one patient with EGFR and ALK, but he was 7 years old. So we thought we'll put him on Jeftinib first. So after a few months, around 6 months, he developed effusion again, and then we started him on ALK inhibitors. Then he improved.
So like I mentioned, they look primary site and metastatic for different alterations. And again, they quantify it. So depending on, found that one pathway may be more active in the metastatic and one in the primary. So that is difficult to see. So one of the things is doing a ctDNA and looking at it.
That's nice. There are some questions. I've seen a patient, Dr. Chetan, with exon 19 and 20 existing together. What is your choice, sir?
So I think exon 20 is a resistant mutation. So you need to look at targeting that. But like I showed you, there is some data with osimertinib at a higher dose.
Okay.
So that could also be an option, because we don't have access to other drugs like poziotinib or amivantamab. We don't have those. So the only thing that we have today is osimertinib. So you need to look at higher dose. And the study actually showed that even at a higher dose, the toxicity was not very great. And since you have nothing else, it is worthwhile trying that.
Okay. Then the other question is that in metastatic non-small cell lung cancer with targetable mutation and asymptomatic brain mets, when should we consider the whole brain radiation versus SRS?
If they're asymptomatic, I will not irradiate. I will look at the activity of the TKI first and then decide on radiation.
Okay. Then any experience of primary resistance to EGFR TKI, how to go ahead with that?
So again, it depends on what do you mean by primary resistance. So for most of the resistance, osimertinib seems to be working very well in the first line. T790M upfront is less than 2%. So that should not be a reason for you to not give osimertinib. Even there it is useful. In fact, osimertinib is used upfront to delay the onset of T790M mutations. So there is nothing really like primary EGFR resistance only for the for most of these patients.
Okay. Another question from Dr. Tasneem. Patient with pericardial tamponade on presentation was initially started with ceritinib. After a PFI of 9 months, he developed bilateral pleural effusion. And do we need a redo biopsy and testing, or do we move to a lorlatinib, alectinib, or chemotherapy?
Yeah, ideally you need to do a biopsy and look at mutations. And as I mentioned, none of the labs today in India have the facility to do these mutations. There are some which have just come in, they're doing with NGS, and I'm not too sure if they're very well validated, but I think it is better to shift. One of my patients who was on ceritinib recently progressed. I don't have the facility for doing this analysis, so I've shifted this patient onto lorlatinib. I believe that is the most active one now, so I've shifted onto lorlatinib.
How is the response to lorlatinib?
She has finished 6 months. The initial assessment has been a partial response, but she's tolerating it well.
Okay. The next question is, if the EGFR mutated lung cancer with asymptomatic brain metastasis, and patient not affording for osimertinib, then should we do radiation first or start the first line TKI?
If the patient is asymptomatic, I will not give radiation. I will start if you believe that they cannot afford osimertinib, I would look at other options. Combining chemotherapy with TKI. That is an option you have.
Okay, in BRAF positive, why can't we not use only trametinib instead of dabrafenib plus trametinib as its downstream pathway blocker?
Yeah, but they've shown that if you use a single agent for these pathways, the resistance occurs very rapidly. So you need to block both. That is why we use a combination.
Okay, Dr. Narendran asked you that NGS upfront and NGS at progression, your comments.
If your patient can do an NGS, I would do it upfront. It's definitely better doing upfront because it gives you a much better picture of what you're dealing with.
Okay, even at progression, we can, if we have not done.
Of course.
Role of serotinib in post-cresotinib patient with ROS1 mutated cancer.
Yeah, we have better ROS targets today, so I think it's better to use that. Serotinib is not very good against ROS as compared to lorlatinib. So in fact, if you can get entrectinib or those, that's even better.
Okay. So far, these are the questions which has come up. Any more questions?
Okay.
Post?